Well, I'll just start. Let's see. Okay, so we're recording. Okay, so I'll just kind of introduce a little bit because most everyone, at least the names that I see on here, if you want to share your beautiful face, that would be great. But if you don't want to, that's totally fine. But we have a couple, I see some familiar OTA students, and we have Joanne Trammell. She's the OTA program director. Anna Alexander, she's a OT in the community here in Pocatello, as well as one of our adjunct faculty. But then we are super lucky this month to have St. Luke's in Boise have some outstanding clinicians helping us with this month's topic. So Mandy Barnes is I don't actually know your full title of something. Oh gosh, Mandy, you'll have to help me.
My title is Supervisor of Outpatient Neurotherapies.
Okay, I knew it was outpatient, or I knew
but
it was
OT at heart.
Yes, absolutely. And then Danica Jones, an OT at St. Luke's that specializes in outpatient, and then currently is going through the steps to become a driving rehabilitation specialist.
Mm-hmm. And then Kim's on too. She's our driving rehab specialist.
Oh, excellent. And
she's
then
fact checking me today.
Awesome. Yeah, so I mean, so the purpose of this is just super informal, but because we're in this world of virtual stuff anyway, what a great opportunity to connect clinicians and students from all over our state, maybe even beyond someday. So I really appreciate you guys coming on and joining. And then thank you so much, Danica, for being willing to talk about this topic with us.
Yeah, so I'm Danica. I graduated from Eastern in 2016. And I did my last rotation at St. Luke's, actually with Mandy. Well, first Brittany for 2 weeks, and then she left me. So then Mandy for the rest of it. And so I just stayed, did my test and everything. And I've been doing mostly spinal cord. It's kind of what my favorite is. And then we needed someone else to do driving, and we felt like with all the hand controls and driving with spinal cord, and I was interested. So kind of been pursuing the driving rehab specialist certification. So right now I'm doing clinical driving evaluations and on-road driving evaluations, or behind the wheel stuff. And then we're hoping to get hand control training completed. It's been rescheduled twice now. So hopefully that will come. COVID is in the way of everything. Yeah, so we're going to be doing that. So today, pretty much, I mean, I'm going to kind of go quickly and briefly over a whole wide variety of topics when it comes to driving. We've got just straight up, what are the Idaho state laws when it comes to what is our role, what are we allowed to do, how is what, you know, what that kind of, all that kind of stuff. And then who plays a role in driving. So how many different people are involved when it comes to getting somebody back to driving. And then what can we do as OT generalists? And then what does a DRS do? And then specifically, how does that all play into rural Idaho, which is the problem that we all have being in such an unpopulated state. One of the things I'm not quite sure, and I think all you CODAs can help out at the end, is just explain like, well, what would your role be based on what you've kind of heard, and how, you know, what you feel like or what you're allowed to do, because I'm not up to date on exactly what you're allowed to do as CODAs. So I think that would also be an interesting kind of conversation to have. But first, what are the Idaho state laws? Idaho is a very laid back state, so there's really not a lot of specific laws when it comes to driving. Essentially, we know that the doctors hold all the power when it comes to driving. That's the law. And then essentially 20/40 vision in one eye somebody has to have. So it's very loose, which, you know, case by case, you know, kind of basis, which is great, but it's also a little bit concerning as far as even the seizure law that doesn't exist in Idaho. Now most doctors follow that 3-month seizure free kind of guideline that everyone else does, but it's not necessarily an official law. Or like in the state of California, for instance, if you have a stroke, then there's a lot of medical ramifications for that. I think it's a 1-year medical suspension, or you need a doctor's note to get back to driving or something like that. So there's definitely a lot more laws in other states. So Idaho's pretty laid back. So I think something, you know, visual fields or cognition or diagnosis specific it makes it tricky in who's driving. So what does this mean for OTs? You know, I think about if the doctor holds the kind of power, the rights to driving, to taking somebody's license away or reinstating it, we as OTs can, you know, the doctor spends 15 minutes with a lot of their patients. And so we can go dive really deep into all the areas, pre-driving skills and things like that, and communicate, send a progress note, talk to those doctors. So communication, I think, is really key, as it is for all of our plans of cares, but I think driving specifically, you have to have that doctor involved in their care. So there's a huge role for us. We can do a lot of stuff. I think number one, we can use our clinical judgment. We say that all the time. But if, you know, the more you kind of work with patients and see things and all that kind of stuff, your clinical judgment is huge. I think a lot of times you meet somebody in the first 15 minutes and you're kind of like their processing speed's delayed. What's going on with their cognition? They're not remembering things. They can't move things, you know, oh, they had a stroke. Sensations, a lot of times a deficit. You know, we can kind of really just from the bat kind of start thinking about what are the skills for driving and what deficits does that patient have. We can also find a lot out of the medical history and chart, you know, looking at their medications and the side effects of those medications. Do they make them more tired? Is there, you know, if diabetes is one of their kind of diagnoses, you know, a lot of times neuropathy comes with that, right? So what about the sensation in their feet? We think about, yeah, muscle relaxers are a huge one. Narcotics, obviously, that one usually the doctor catches, right? But you can learn a lot, you know, is there emphysema or is there some COPD? Are they on oxygen, for instance? How does that affect their just ability? If you think about, if you have oxygen, you have to climb in your car, carry all your equipment, unload, do whatever you're going to do, come back in the car and safely drive home. You know, you think about all of the physical and how much that physical fatigue can impact your cognition, right? And your reaction speed and processing speed and all that good stuff. So, yeah, looking at their chart, you can do a thorough chart review. And we always joke when we do clinicals, we pretty much can tell if someone's going to pass or not just by reading the chart. You pretty much, if they have a mild cognitive impairment and they have comorbidities, we can be like, all right, they're probably not going to pass. And most of the time we're right. Now, there's always the people that surprise us, and that's why we have the driving evals, and that's why we do it. And we don't want to take anybody's independence away that doesn't need it taken away. So I think that's huge. Clinical judgment, medical history, I think is what, especially when it comes to the rural areas, that's what you're going to be using. But for our driving evals and our fit to drives and all that kind of stuff, we look kind of divided up into three things. We look at physical skills, visual skills, and cognitive skills. We try to keep it really simple, straightforward, very research-based. And so if we look at physical skills, we're looking at range of motion, strength, and sensation, something that we do on eval day every single time, right? So a lot of times, you know, before you even start talking about driving, what physical deficits are going to be. Can they move? Can they get in and out of their car? Do they need an assistive device? Can they manage that assistive device? Where's the sensation deficit? If it was a stroke, is it a right-sided stroke? Well, now all of a sudden can they move their right foot? What's the plantar flexion? You know, so there's a series of physical, you know, things that we can look at. Visual skills, we can, you know, we as OTs, we're allowed to do vision screens, right? Now, be careful in your documentation and how you do that, as we're not optometrists and we've got a huge, you know, we let them do their job. But I think there's lots of little screens we can do, or a lot of times if they haven't had a vision test and we kind of do a quick screen at distance acuity and say, hey, your vision is far less than perfect. When's your last eye exam? You know, can you go back to your eye doctor and get that checked out? We do a lot of confrontation testing, visual field testing, and that's huge. I mean, if you think about, you know, while we don't have a visual fields law in Idaho, the likelihood, and there's lots of research to support it, but the likelihood of somebody passing a driving assessment with homonymous hemianopsia or some of that kind of stuff is, I mean, I think I've had one or maybe two in the last 4 years that have passed their driving tests, and it's been those really young folks that it's their only deficit after a stroke. So very, very rarely do we have somebody who passes those the homonymous hemianopsia or a significant visual field deficit. Now, I actually recently had a patient who came back, they had homonymous hemianopsia. Oh my goodness. They had that diagnosed, and the eye doctor goes, "Oh, you can drive. I don't see any reason why you can't." And I was like, "Oh no, you can't." And I was doing not just from a vision standpoint, but cognition. He was not in any place. I mean, I wouldn't even send him for a driving eval because he wouldn't pass. And so that was a time when I'm like, come on, eye doctor, like think about the whole picture of driving, not just their eyes and not just the law, right? There's so much more that comes to driving besides just, can you see a little bit out of one eye? Because there's no law in Idaho. So, but visual skill or physical skills, visual skills. And then lastly, we really look at cognition. And this is where we can hang out a lot. When it comes to driving, there's a lot of assessments out there, but there's not as much research as we want. There's a lot in some areas and not a lot in others. I think first we look at the ADLs and IADLs. I always say, if you can't organize your pill container, then cognitively, then how am I supposed to let you drive a vehicle? If you can't, minus the physical skills when it comes to like spinal cord injury, obviously we can get around those, but if cognition is getting in the way of sequencing their basic ADLs, then they're not ready to drive. And there's quite a bit of research for that. But specifically, the ACL and the CPT are two really good assessments. I know I spent a lot of time in school on the ACLS, and I still don't know why, but there's a lot of research on it. And anything less than about a 4.7 raises some huge driving concerns. And we're not even looking at anything to do with driving. It's all can you make some toast? Can you, pick the appropriate clothing for weather, all those higher level executive functioning skills, processing skills, sequencing, planning, organizing, all that stuff is all related to driving. We have the Dynavision in Boise, which a lot of clinics don't have. And so we use that a lot in our general OT kind of screen. I'm looking for that 200 on the 4-minute endurance test. More recently, we've taken the MOCA out of our kind of OT generalist screen because of the overuse of it and because now it requires that certification. And so I always say, a lot of times, even when we do our clinical driving assessment, somebody's done it in the last month. And a lot of times we just take that score. So if a neurologist has done it, things like that, if you see anything less than an 18, it kind of throws up some big kind of red lights of saying, or yellow lights of like, this needs to be looked into a little further. Because the MOCA is not end all be all by any means, but it does kind of give us some good insights into where we're at. Anything about 26 is normal. So if they're scoring an 18, that's 30 is, we're not even looking for perfect. It's a little bit above 50%. So I think that's something to consider too, is like, that's pretty impaired if you're below 18. And I automatically, we don't, a lot of times when Mandy or Kim does our referrals and stuff like that, if somebody's getting a 7 or a 10, it's just like, just say no as a provider, as a doctor, just say no, because it's just, that's not going to work. Brain HQ, this has been something we've really brought into practice, I guess, maybe the last, for sure, year, if not 2 years. And that is a research-based program that anybody has access to. It is about $100 a year if you do it, but it has a lot of research to support processing speed, attention, divided attention, cognition, things like that. So we have access to our clinic and actually use it kind of as a screening tool. Like Meridian doesn't have a Dynavision, for instance, so we kind of look for that magic, 100 milliseconds on certain Brain HQ items, and that has that's kind of the useful field of view is kind of the assessment associated with some of those assessments, and that can also give really good insights into driving. We don't have that yet. We're hoping for it sometime, but I think Brain HQ is cool because you can use it as treatment and kind of as a guide to kind of help steer you as far as, are they getting even close to their processing speed required for driving? Again, it's not an assessment, it's not an end all be all, it's not standardized, but there is really good research to support how It can improve somebody with a neurological injury in the ways of processing speed, attention, memory, all that good stuff. So something to kind of, I know I love it. I hand it out to everybody. It's super, super helpful. And I've seen really awesome, I think the cool part is like functional gains. So even though it's this computer program, I've seen it improve so many areas in people's functional life too. So I always say, well, I'm not just giving you a game to give you a game. You know, it actually works. So I think kind of as a OT generalist or a CODA, I know there's lots of ways you can be involved in this too, but ours kind of looks like this, and it's under revamp. It's called the OT Fit to Drive screen. And we look at, again, we split it up into vision, physical, and cognitive skills. And then there's always a spot at the end that's like, what is your clinical judgment? Because at the end of the day, that's what matters. You're piecing it all together, and you're the one making this whole statement and recommendations. So yeah, we use the Dynavision on that. We use, just can they get in and out of the car? Like, where are they at on that? Their motor skills, their physical skills, visual field testing, acuity, impulse control. And that's kind of a subjective, there's not really anything objective for that, but are they impulsive? I think is a really good statement to ask yourself. If they are, then they probably shouldn't be driving. They need to be able to, control themselves, their behavior. So, and then I guess getting into the DRS kind of comprehensive driving program, we have one in Boise. So I think if you were close by, send them over. I think even when I've only been doing this, about I don't know, been working towards it, I feel like for a year, but probably a little less than a year. So we think about it, like before that, I loved sending them to my other coworkers because whatever the outcome was, it saved my relationship with the patient. It was much easier for me to go, let's give it a go, try that driving eval. They fail. I go, all right, well, let's look at it. Let's do some deficits, and you can keep on treating them. If you are the one doing the driving test and making that final call, it can put a huge, huge impact in your relationship. Maybe driving's not in the cards for them, and that's not a good idea, but maybe they can still live on their own with extra support, or maybe they can still do all these kind of things where an OT would still be really valuable in their life. So I think it's always a good idea that if you can, send them to that third party. I'll even do some of Kim's. Kim will do some of mine, just to have another set of eyes, another look. When I do a driving eval, a clinical driving eval, I do all the cognition, everything like that. Sometimes I go, you know what? I'm going to rate you as a moderate risk for collision. And then actually I'm going to send you to my coworker to do the actual on-road behind the wheel assessment, because I just want to make sure that we're keeping everybody safe here. Right. And another kind of look. So definitely, I think it's a good idea. If you have access to one, use it. Twin Falls is expanding theirs right now. And I think Kalispell has some extra kind of knowledge and specialties over there. I know for sure they have a driving simulator and stuff like that up in Coeur d'Alene. I don't know, Kalispell has one too, but Coeur d'Alene. So I think there are some around. It's not uncommon for people to travel a long ways for driving specialties. There's not many of us in the whole states, so all the United States. So that I think is the first thing. I think if not, obviously, right, there's plenty of rural areas that it's like somebody is not going to go 2 hours to take a driving test. It's expensive. You have to pay for lodging. They have to get there. They have to get back, right? There's all these other barriers. So that's kind of where it's important to have that relationship with your provider. You can get together with the DMV. The DMV, if you do that certificate of medical exam, the doctor can request a driving eval, and they can do it on kind of an on-road, similar to what you do for driver's ed. But again, they're not assessing the rest of the person, the whole person. They're just saying, can they drive? So it's not ideal, but it does work in a pinch. And they can also do the cognitive, like the written test portion as well. But again, it's just that 20-point test. So is it really giving if somebody had a good memory and they could memorize all those tests, they could get right through it. Sometimes I do think that the DMV one might be harder if you to back around a corner and parallel park, whereas we don't have to do that in ours. It's just a safety test, a safety measure test. So in some ways, it might be really tough and very enlightening doing something like the DMV, but it isn't, it's not first choice. See what else I have on here. Yeah, so I think the big thing is if you have a pretty good idea, if you team up with a doctor, look at their medical history, look at the cognitive skills and the physical skills that they do have, use the CPT, use the ACLS, whatever, those are great assessments. The MOCA is good. It's just way overused, as we all know. We actually originally had the MOCA B on our Fit to Drive screen. So it's a basic version. It's a little less probably used, but it's just a different version, kind of helped create some variety. So that's kind of as far as rural Idaho. There's not a lot. I think, how do you create one of these? I was thinking about if you were going to do a Fit to Drive screen, or you were going to kind of create like kind of something for your clinic. We've got all of our information pretty much from the AOTA practice guidelines. There's one for specifically driving, the OT generalist, and the DRS, what the roles are, what that looks like. It's pretty brief, but it does kind of help kind of support and provide guidelines. I think when you do create a document like a clinical driving assessment or something like that, you better have your list of resources and evidence to support why you're making the claims you're making, because driving's a big deal. A medical document is a legal document, right? So if it was subpoenaed, it's used that way. So you better know what you're talking about, I guess, if you're going to determine somebody's ability to drive. And then, the other big resource we used was the National Highway Traffic Safety Administration. And this, I think, this is a great resource, and that goes into depth, a little bit more detailed videos and resources as far as like what are our roles as a therapist, and what can we do, what we can't say, what we, how does that work? Pretty in-depth stuff. And they're all for guiding our practice, which is nice. It's not from the patient's point of view for the National Traffic Safety Administration. The AARP and stuff has some stuff for patients, or there's some other resources online, but honestly, they're not that great. I think you can come up with a lot more information coming from your clinical judgment and from all the things we've kind of discussed today. Yeah, so that's driving in a nutshell. I think my last kind of plug is looking at your liability of what you're saying and your documentation and how you're communicating that. Because I think being careful not to say dramatic and drastic statements like this patient cannot drive, or this patient is cleared to drive. We don't have that authority, even as a driving rehab specialist, to say that. We can say, based on my clinical judgment and all of these deficits, this may impact a patient's ability to drive, or may impact their performance in driving, or IDLs or something like that. We can say recommending a comprehensive driving evaluation, or recommend clearance by medical provider before returning to driving. But at least we've been instructed not to specifically say they can't drive, because it's not the doctor's role is to do that and make that final call. So yeah, I think driving's a tricky thing, and I think it can get messy really fast if you don't have those clear things, which is why a lot of our therapists often they'll just kind of either send them over to the driving side of things, or they just don't really talk about it at all, because they don't want to get caught up in the middle of it. But there's a clear role for us to do so, and to help keep Idaho specifically safe. I think we have the highest number of fatalities caused by drivers over 65 in the whole US. And it's because we don't have the regulations in place. We don't have the laws in place. Now, some people take that and go, well, it's awesome that Idaho is able to take it by a case-by-case basis. But really what we're finding is people are just not addressing it. They're just saying, my grandma was 95 and was still driving. It's like, well, that's that was probably not best practice. You know, like she probably shouldn't have. Now I've also done driving evals on 90-year-olds and they killed it and they did amazing. And she showed me her Pilates, you know, studio on our way by, and it was pretty amazing. But for the most part, most people, you know, we have the number one of fatalities for a reason, because we don't have a lot of support from a legal standpoint. So I don't know. I mean, that was kind of my quick and dirty version. Any questions, or can we talk about, or what's the CODA role, or what do we, you know, what do you guys see? You don't have to talk to me either. It's fine.
Can you talk a little bit about your on-road portion? Do you do
Yeah. So we do an 1.5-hour clinical driving assessment. And that's all in the clinic. So like I said, it's the 1.5 hours. And then on a different day, we schedule the behind the wheel. It's 60 minutes in the car. And we have this, we have two routes we use. The first one is more of it's a little bit briefer. It's somebody who just did phenomenal on their clinical. And we, you know, we still hit the major points, but we spend a little less time in the neighborhoods, and we cut across and jump on the connector and hit up the highway and stuff like that a little faster. Somebody who's more of a moderate risk, or somebody who we're kind of, you know, we want a little more time before we hit the higher speeds. It takes about a full hour. And we go through neighborhoods. And if you've ever been on the north end of Boise, it's actually pretty hard to drive. There's a lot of hidden stop signs. There's a lot of bushes in the way. There's a lot of cars parked along the way, all the sides, on both sides. You have to pull over to let somebody drive. You know, it's pretty tough. And then we go down, our goal is to hit all of the major things you would need for driving. So 25-mile-an-hour speeds. Can you maintain 30 for a long time, which somebody with, say, dementia, or you know, mostly dementia, they'll go slow to like 15 miles an hour, and they'll do that for a long time. And so they're not maintaining their speed, you know, they're going way under or way over. So we try to hit all the major speeds. And then we merge onto the connector, and then we go down Broadway and then hit up Broadway back to the rehab. So if you know kind of where Boise is, that's what we do to try to see everything. We don't parallel park, drive, you know, back around a corner. We pretty much, it's just, are you maintaining your speed? Are you stopping at stop signs? Are you aware of your surroundings? Are you being aware of pedestrians? You know, we go through a couple school zones, which this year hasn't really affected too many of them because they haven't gone off. But for the most part, you know, it's like all the different, we have roundabouts involved, and the blinking stoplights that they've put in, that they can be kind of like all the flashing and stuff like that. So we tried to do that. I think it's a pretty good representation of everything you would need. You know, you get up to 65 miles an hour, and you come around, and there's a couple of left-hand turns that can get a little sketchy because, you know, of the double turn lanes. So it's pretty good. Yellow flashing, blinking lights on State Street. So that's kind of what we look for. And then as we conduct them, we do a mixture of make a left-hand turn on this street versus, you know, turn left here or there. You know, there's no distraction in the vehicle. We just, it's, you know, there's no music or anything going on. It's very much, we try to keep the patient from saying a lot of stuff, conversing if it's impacting their driving. My goal is not to, you know, I think our goal is to at least, you know, we're not testing their ability to drive our Nissan, right? So we try to get them really comfortable where they're at, and because it's tricky enough somebody driving your ability, you know, testing your driving, and then on top of that, you're in a car you don't know, and then, you know, so that's kind of, does that answer the question?
Yeah. Do you do this as is it a private pay, or is it billable at all?
Yeah, so we kind of have a mixed system right now. If they're a current patient and they're being seen under OT and driving is a goal, right now we're just putting it into our plan of care, and we haven't had a problem, at least to my knowledge, getting it covered. But if it's somebody right off this kind of the neurologist sends it right over for an eval, right now it's a cash pay system, which we've had a lot of discussion on is that ethical? Like, because technically you're doing the same service, and one, you're requiring cash pay, you're not billing, and other, you are billing. So we're kind of actually literally the last month or so, we've been really revamping that. I'm taking a look of saying, could we get it covered as a one-time eval, or could we, you know, go that route. Because it does make it more accessible if their insurance covers it. Not everybody can afford a $200 hour and a half driving eval followed by $100 or $150, I think it is now, on-road driving assessment. It's expensive. So yeah, that's something that we've been really talking about. And then hand control training, we've been doing, evaluate them as a normal OT patient. Typically there's needs that need to be met, trunk control or stability or strength that needs to be kind of addressed first. And before we do that, so we just kind of do a few OT visits, make sure that those skills are all in order, and then do our hand control training all under their insurance. So I think that will probably, all that stuff is kind of moving right now. So we'll see what happens.
So I'm doing something similar in Eastern Idaho. I don't know. I mean, I'm dabbling in it a little bit, but but it sounds pretty similar to what you're doing, except for like I'm not doing the on-road portion because I'm not qualified to do that. So anyway, just but this has been great. I really appreciate.
Are you sending them to like the DMV to do them, or are you just is the doctor clearing them based on?
No, so I've contracted with a driving school and they do it. I'm in the back seat, but they do the actual driving test. So.
I've been doing all my training. I'll just put a plug in for Susie through Adaptive Mobility Services.
Oh, cool.
It's expensive, but it's worth it. It's been worth every single penny.
There's definitely needs. I mean, there's a huge need for it, and that's not going away. So.
Yeah, and she has been so helpful. We've had many one-on-one hours of conversation outside of the amount we've paid to get all the training done. And it's a hybrid where it's you can look at it, but it's hours and hours. I think 40 hours in the clinic, all clinical, just videos and stuff like that. And then she comes out for a couple days and teaches you all of the on-road stuff. And it's awesome. She's fabulous. So I think with that has just given me, even if you could just do the building blocks, the first part one, and then you could do the part two later or whatever, so much foundation. And she goes everything from she treats it as you don't have a driving program at all. And it's been really, really helpful, and just understanding the foundation, everything from like how much liability insurance you should have, like if taking on this extra, kind of thing and she just kind of pressures you into, you need certain program guidelines, you need certain policies, you need certain things that you're like, oh, I guess you would need those, but you don't really think about it until you are subpoenaed, right? Like until somebody's like, what are your methods? And you're like,
right.
So she's worth it. And she offers a lot of just like little free lectures here and there too, once you get on her mailing list. And
oh, cool. I'll look at
she's really sweet.
So Danica, I'll talk about as far as the CODA's role.
Yeah.
Like that in our program, we go through assessments quite a bit. Our students come out familiar with like the MVPT, Brittany does a good job in neuro with vision assessing in general. They learn the slums. We talk about the MOCA. Totally. We learn the ACLS.
Perfect.
We have the CPT, but I didn't get it out last year, but we have the ability to do that.
Yeah. I
have seen documentation where kind of like the MOCA where OTs up above my pay grade question whether an OTA can really do the CPT. But in my opinion, they can do the parts that are assessments and then give it to the OTR for the interpretation aspect of things. And this is all based on service competency, obviously. So we talk a lot in our program about service competency, in that it's the OTA's job to seek the supervision, to encourage their OTR to sign them off to be service competent and keep that documentation so that they can help you guys with these type of assessing to, like we talked earlier, helping with the caseload overall.
Yeah, I think, all that is super helpful, I think. And just, the other cool thing about having a partnership between a CODA and a OT is you're both seeing them. So you both have a different eyes, different interpretation, different thoughts, different, all those kinds of things. And we always say, two heads are better than one. So if you're both kind of on the same page, you're going, yeah, they're ready for a driving eval, or, oh yeah, they're doing great, then I think they probably are, you know. And so that's really cool. I think.
Yeah, and like you were talking earlier about, what I was hearing was the good cop, bad cop. So the OT is like, okay, I'm going to give you to the OTA here, and she's going to do this assessment stuff, and then it can come back to the OT that says, no, they didn't really make it, and then the OTA can kind of pick up the piece, help them figure out where we're going to go from there if it's not a great outcome.
Yeah, I mean, I haven't done the clinicals long enough to run into it too many times, but I for sure a couple years ago have sent them over all those people on the edge, and they still leave OT as we discharge them on a happy note, even though they didn't do well, because, you know, we were able to say, well, maybe in a year.
Therapeutic use of self.
There you go. Cool.
I wanted to, so Lisa, I know in Eastern Idaho, I would say you're kind of the main person I think of for driving at this point. Would you say that with what you've been doing, do you have good physician buy-in, physician referrals? Like, how is that in Eastern Idaho? Because I think, like, Danica, you guys probably have a pretty solid backing on your physician teams, your referral sources, just the community is established in Boise. And I really appreciated that when I was there. I was just curious because the little bit that I've come across it in Eastern Idaho, I've struggled.
Yeah, I mean, I haven't marketed very well yet because I was working through ISU and then I left that. So it's now in my clinic in Idaho Falls, and it had to do a little revamping at that point. So I really haven't been ready to like have volume come in.
Yeah.
I know that I've had some physicians who are like, oh my gosh, you can do that, you know. But I think a lot of people are really unclear, like Danica was saying, about what are the regulations, you know, when can they drive? And so I really don't see a problem with, you know, establishing that. I think it can happen. It's just a matter of being ready for the volume.
Yeah, for sure.
And then Voc Rehab has been another place that has contacted me. I'm sure you guys work with them too, right, Danica?
Yep.
And I'm also finding that there are a lot of like adolescents on, you know, probably on the autism spectrum or anxiety, that type of thing, that are really having a hard time just fitting that normal, you know, take driver's ed, pass the test model. They're not succeeding with that and need a little extra. So
we've done that's been she's done all the legwork for it, but really, really educating Voc Rehab on what's an appropriate referral, what's not an appropriate referral. We've gotten improved our relationship with our own peds department, of just saying, you know, whose role is what. And a lot of those kiddos need that extra kind of life skills stuff first, you know, before kind of do an eval with them, do some treatment with them, and then kind of transition into this. Because exactly what you're saying, like a lot of those kiddos on the spectrum and things like that, they also get kind of discharged from therapy, right? And then they're not seen for a really long time. And then all of a sudden they can't pass driver's ed, and things like, because they need extra support. That's been a really interesting, kind of conversation with the peds that they're saying, that's not my role. And we're like, well, it's not our role. Like, you know, so we'll do the driving part, but we need, you know, they're still under that caseload, you know, even if they are 20, right? They still are kind of in that same kind of area of their skills are more pediatric as opposed to an adult, you know.
And again, that's a good partnership with a COTA, just, you know, because it's not an OT that has to do that treatment, you know. So
totally. I'm really, really not, that's not my skill point, is anything on the spectrum.
Right.
I'm like, oh boy. Those are, I see that I instantly get anxious.
Yep.
Yeah.
Well, and I'm wondering, so I do home health, and I feel a lot of times that I almost have to justify to the doctor why this person may need further intervention with driving or may not be safe to drive. And, you know, I've got some quick and dirty assessments for cognition and, you know, physical disabilities and all that, but I struggle with the reaction time part of it, and how I can briefly assess that to give the doctor some foundational, this is proof that this person needs further intervention in this area.
Yeah.
Do you know of anything? Not to put you on the spot or anything, but
I don't know if Kim's listening at all. Kim, I know you're on there. But I believe that, so.
I'm here.
Oh, you are. Good. What about home health and processing speed? Brain HQ?
Yeah, I was just going to say, Brain HQ is a good, like Danica said, it's absolutely not an assessment, but I would think of it as a tool that could help you determine if they're having delayed processing speed or even scanning deficits that would show up in that. That software will give you some data based on the patient's age, if they put in their age, and it tells you what percentile they're at. The trouble with that part of the program is that's a bit deceiving, because they could do really awesome on one activity, and there's probably 30 on that website, and then really do poorly on another, and it might put them at like the 40th percentile. And so we've functioned off of looking more for a raw score of less than 100 milliseconds on any of the processing speed stuff. And I've been using that website since I've been at St. Luke's, and probably about 10 or 12 years now. And it's pretty reliable that if someone can perform consistently faster than 100 milliseconds on some of the processing speed activities on that website, and that's one of the categories, they're probably going to do okay if they were to do a comprehensive driving evaluation, say with Danica or I or somebody in one of your communities. But it's also not a guarantee. So I always emphasize 100 milliseconds is the bare minimum. That means there's a chance you won't do well on clinical testing. So you still got to work on it and try to get faster yet. So that might be a tool for you. Of course, it's not an assessment that you could really cite to the physician, but you could,
right.
in terms of activity, the only other thing I could think of for you for home health, maybe.
What about Trail A and Trail B? Is that not?
Hey, Joanna. Yeah, it's Kim. So there's a lot of controversy about that. I'll let Danica speak to that a little bit, and then if needed, I can give input.
Yeah. So Trails A and B, I think the hard part, so all of our clinical assessment, I guess I didn't go into too much detail about what's on that, but we do the MACE test, the MOCA, Trail A and B. Oh gosh, and then a whole bunch of physical cognitive skills and things like that. Trails B does have good research to support regards to driving. It's actually, I think, one of our big kind of like powerhouses. If we're trying to determine if somebody's on the edge, we do use that one a lot. The thing is, it does require that special training to administer it. And at least like Kim and I are the only two actually OTs trained in that here. Mandy is too, but she doesn't treat many patients anymore. But and I think that's coming from our neuropsychologists. And I think just standardized testament, they're trying to keep the validity of it. So that's where I think the main thing of where it's probably not, it has to be on special paper technically, and special conditions, all that kind of stuff. Now people do it. But
that's new to me, because I remember learning that way back in my day, and I used it in rehab. We're talking 20 years ago, so I didn't realize that was something you had to be trained in.
Yeah. Kim, do you know more about the training?
I was just going to add, the big issue with Trails B is that there's Trails A and B, is there's lots of versions out there. Even in the resource Danica cited, the National Highway Traffic Safety Administration Guide for Assessing Older Drivers is what I think they used to call it. There's a version of Trails B in there, and it is not the standardized form or version. So then you can't use the normative data because you're not using the right test. And so that's one of the challenges, is like so many versions of it got out there, and people were thinking, oh, this says it's Trails B, cool, I'll use it. But you have to administer A first, and then you have to be using the right form, meaning, how they're placed on the page. And so that's where there's been some trouble. The neuropsychologist will tell you that if an OT is going to administer it, they have to have a master's degree and they have to have demonstrated competency to them. That's been what was advised when I worked at STARS and then our neuropsychologist at St. Luke's Rehab.
And that makes me think, like, if in Anna's situation in rural Idaho, home health, using it as a screen, I think I know like maybe higher ups than us would not be super great about us doing that. But if we had said in some regards in our documentation that it was not in the standardized format, which then maybe it wouldn't carry as much weight, but if it was used as a screening tool versus as a end-all tell-all assessment, I mean, I know from your guys' standpoint, I'm assuming that would still be a no-no, because I still remember that from my time at St. Luke's, but I've used it in the home health setting in rural Idaho, where we just don't have as great of a team, and we don't have the neuropsychologist at least readily available. I'm sure I could find one, but it's not a part of our normal like process to just refer them to neuropsych for
I
driving.
don't even always have access to data or Wi-Fi or anything like that. So using computer-based things is really difficult as well.
Yeah, you're in a tough spot. I think even, that's super tough. Because even if you use it as a screening tool, it's not standardized. So then all of a sudden you're telling somebody that they're in the 50th percentile, and you're like, well, actually they're not. We don't really know what percentile they are.
Yeah.
So then it's essentially using something like Brain HQ is also a screen, so it holds about as much validity as,
But it still could be at least something to help Anna's clinical reasoning to make a determination or see if she could get that referral to a driving specialist or further, I mean, if there's neuropsych or whatever involved.
Yeah. I guess you'll have to deal with your clinical conscience. Because I'm not in your shoes and I can't, you know what I'm saying? Like right now, that's a hard no. I wouldn't recommend it to anybody. We're not allowed to, whatever, that's been drilled into me since day one, but I see exactly where you're coming from. I don't even know what I would do. Like that's really, that's tough. Like, I mean, yeah.
That would be interesting to find out, just like an IOTA poll or maybe even an AOTA poll, how many OTs have been trained not to do trails A or B unless they were, certified or formally trained in it. Because I feel like I didn't hear that until I was at St. Luke's either.
One of the ones that, and this, I don't know how much processing speed, but it might be another tool, would be the BCAT. That has actually a lot of testing and stuff like that done in regards to driving, a lot of research. And that's actually one of Susie's, the gal at Adaptive Mobility Services. She's a big, she loves BCAT. She thinks it's the best. So I think that could be another tool maybe, because the MOCA is so widely used, or it doesn't give you enough information. The BCAT's a little more comprehensive. And so, we're not really supposed to use that in St. Luke's either, because the speech therapists use it all the time. And so we're trying to allow people to have kind of their role. But again, in home health, rural Idaho, how many speech therapists are going to be pulling out the BCAT? Probably not often. And if they do, I think you can use that data, if it's been done recent enough, to kind of help your clinical reasoning as well. That might be another solution. Because there's some good research on, the BCAT. I think if you did, you kind of did a variety of those things, put together your own fit to drive screen based on, everything we've talked about, then also the OT practice guidelines and some of the research, you probably could get away without doing trails and still have enough evidence to support no driving or extra testing needs to be done. Does that make sense? Because usually, not always, but a lot of times when people fail hard on those clinicals, it's multiple areas. It's a kind of a comprehensive decision. I would say rarely do I look at just trails A and B and go, nope, no driving, So I think that's also something too, is like there's, you might not run into that as often as you think you would, because they don't do well in a lot of other areas. You know, if you put together a comprehensive driving or a fit to drive. I'm not trying to
And can I just clarify, Brain HQ, that is a yearly subscription?
You can do month to month. You can also, I think they still have a free version. It didn't work that great when I did it, where they trialed like 4 activities. But it is a yearly subscription is how we pay for it.
So St. Luke's has an account, so like an agency or whatever could get an account, and then any therapist could have access to logging in and doing their.
Kind of. I know Mandy had to buy 4 logins, so I don't know what
you
the
have to
pricing
buy
is.
a license,
Okay, gotcha.
So,
but it's cheaper than buying 4 subscriptions kind of deal.
Yeah.
there you go.
And it's similar to like the mindset of Lumosity.
Yeah, except for it has evidence to support it. So Lumosity had to take off all of their advertisements and everything because they were claiming things that weren't true. But Brain HQ, I mean, if you go on there, it's actually, I'm not like, I'd say a medium on liking to read research. There's some interesting stories and really cool stuff of people of all neurological places. I mean, professional football players use it after concussion recovery for processing speed and attention. And you have all different lifespans. So they have normative data from stroke to concussion to young people to old people to Parkinson's to MS, all this stuff. Hundreds and hundreds of research articles. They have 10-year studies on some of these things. So it's pretty, if you're going to be doing a lot of rehab kind of stuff, it's hands down worth it. And some of it's really hard. I've sat there and done it and checked them all out and see what they're like. And it's not necessarily easy. But yeah, it's been a game changer for home programs. Now, for the older folks who can't operate a computer or complain, it's not as cool. It makes your job a lot harder. But yeah, so I mean, it's not easy, that's for sure. But more and more of the older folks are at least getting tablets now, and there's an app for it.
Yeah.
And so it's a little bit easier for, us to come up with a tablet. I think I'm seeing that more and more, or having a smartphone. I see more older folks with iPhones now. And there's an option on that. So that's helpful. But yes, I imagine rural Idaho, they don't even have cell phones half the time. So it makes it really hard.
We're not all quite like that.
Yeah,
Or maybe
that's
some.
tough.
Hey, Danica, it's Kim. Another thing to know about Brain HQ is they work with the Department of Defense. And so they also offer reduced or free memberships to active duty and retired military. You kind of have to search for the info on their website, but when price or cost is a burden, if you can get over the technology being a burden, at least for some of those folks, and again, active and retired, there's a way to, I haven't had to do it yet, but a way to apply for it, I guess is the way I'm going to say it, and get it.
She muted herself.
I did. I was done.
Oh, I see.
That's cool to know.
Yeah, it's a cool program. I love it. It's weird once you have used something for so long, like in your practice. So I have the Dynavision and the Brain HQ every single day, that I'm like, I don't know what I would do for half my treatment sessions because they're already filled up. Like, it's just crazy how you get used to what you have, and it's awesome. I mean, we have a lot of cool stuff, so it's helpful. It makes our jobs easier. You have a much harder job.
Yeah, but if it's only like $100, I mean, gosh, Heritage should buy, I mean, depending on how often it would be used, but that's
even one license, because you could, use it in the clinic, all the stuff. I mean, I think the best part about it is the amount of research they've spent into it. So it's a little bit easier to justify purchasing by like an employer, because you're like, well, it's actually a real thing. It's not just something somebody made up.
Yeah, it's not the Wii.
Exactly. which I imagine probably more skilled nursing or home health agencies have WEs than than we know what to do with.
Danica,
Mm-hmm.
what about in home health? What about that reaction speed tester that Susie talked about? It wasn't super expensive, was it?
I don't know.
Remember, there's some kind of, it's I don't know it well off the top of my head, but if a data mobility Facebook almost daily, that's awesome resources, but there's
You're cutting out pretty bad.
something that, oops. I'll try again. I don't know, it might be my Wi-Fi. Action speed that the patient pushes with their foot.
Oh. Something that the patient
Nope,
pushes with their
not
foot.
working, I don't think.
I will look on
Yeah, the reaction speed.
I'll look on I still have access to all the training, so I'll do that, and then I'll talk to Kim tomorrow. And then we can maybe get some more information on that. The other thing, like, I don't know, I know Susie's not going to love this, but if you do look up her website and you just send her a quick email or something, just be like, hey, I need something in rural Idaho for processing speed. She's the sweetest little nicest gal ever. She probably would say, oh, here, how about this? That might be something. Like, anybody who's willing to invest in driving and keeping in programs and things like that, I'm a student of hers right now, so I think that's helpful and that she's willing to help me. But I get the impression that if you were to send her a quick email, she would probably have no problem kind of helping you out, because she knows that stuff. She's been trained by multiple people and then has built this program in this huge education program. Like, she knows what's happening. So it might be something to kind of look into. Any other questions?
Well, I'll jump in and just say thank you again so much. I really appreciate, Danica, your support and just the representation from St. Luke's and Boise. That's super exciting. And I feel like this has been really beneficial for a lot of us, connecting, just getting to new clinicians, new faces, access for our students, things like that. So I'm just going to do my little plug here we're doing this every month. I solicited a speaker and a topic, but if somebody has anything, I'm dying to share this greatest thing that I just found, or I would love if someone had any experience with whatever, I'm trying to make this where it's beneficial for all of us clinicians. It's connecting us, it's uniting our state. And then
also,
yeah.
You can also like throw somebody under the bus and say, hey, I know so-and-so is really good at this and I'm going to volunteer them for next week, because if they're not here, they can't say no.
Yeah, so I'm hoping, every month, the first Monday, 6:30 seemed to be a better hit than 6, so I'm going to stick with 6:30 for right now. But again, thank you all for joining us, and I'm going to do something with this recording, but I'll at least hold on to them, but try to get it where we can get out there and kind of get a bunch of us together. So thank you again so much. I really appreciate it, and this has been awesome.
Yeah,
Thanks
you.
everybody for coming.
Thank you.
Have a
Bye.
wonderful rest of your Mondays.
Bye, Brittany.
Bye. Good to see you.